Okay, so this is a patient who came in. You can already start to see that there's multiple findings in the abdomen. There was a large mass in the kidney, as well as perinephric soft tissue. And then also soft tissue infiltrating the psoas and these muscles and in the gluteal soft tissues back here as well. And even some soft tissue around in the perirectal fat. You can see all this like obliteration of fat planes. So this kind of goes into the differential of perinephric soft tissue. Anyone want to give your differential? If anyone's chatting in. Okay, I'm getting lymphoma, perfect. Vascular malformations, amyloid, lymphangiomyomatosis, retroperitoneal fibrosis, extramedullary hematopoiesis. Perfect. That's the great differential. I would say probably we should say lymphoma first, since this is multi-compartmental and that's going to be more common.
Also sarcoidosis.
Sarcoidosis, good. Yeah. So all of the zebras. So amyloid, sarcoid, extramedullary hematopoiesis.
Erdheim-Chester syndrome.
Yes, Erdheim-Chester, exactly. So this is the differential. So lymphoma, metastatic disease can do this. Somebody put lymphangiomatosis, excellent. You can get a lymphangioma that surrounds the kidney. Retroperitoneal fibrosis, extramedullary hematopoiesis. So I always look to see if the patient has a history of bone marrow replacement or myelofibrosis. Amyloid, Erdheim-Chester, so look at the long bones. Rosai-Dorfman's also rare. This patient got biopsied, both the perinephric tissue and the gluteal tissue was biopsied, and it came back inflammatory pseudotumor. So these are rare benign lesions. It's more common in children, also in younger patients. It's basically a diagnosis of exclusion, but just know that it exists. On biopsy, basically they'll have a polymorphous infiltrate. You'll have a lot of fibrosis, T and B lymphocytes, which is what will distinguish it from lymphoma. So you won't have a clonal proliferation of one type of lymphocyte, which is what you would see in lymphoma. You get necrosis, granulomas. Two things that are more classic are if you see these myofibroblastic spindle cells, in which case they'll give it the name inflammatory myofibroblastic pseudotumor. 50% of them will also stain for ALK, which is anaplastic lymphoma kinase. And then they can be associated with infections such as EBV and mycoplasma, and also associated with IgG4. So on the pathology specimen, they will stain for these different things and look for any organisms or any signs of IgG4 disease. This is all from this article, Inflammatory Pseudotumor, the Great Mimicker, which was in AJR. So the most common areas are going to be the lungs, especially the pleura and the orbit. But you can get them anywhere in the body. So for example, this was a younger patient with a large, mass. It could have been a lymphoma, could have been a sarcoma, but in this case, it was an inflammatory pseudotumor. And they can be malignant, rarely, and metastasize. So this was one that had metastasized to the liver. And it can basically go in any organ. You can have it within the liver itself. You can even have it at the hilum. This, basically, we would have said this is malignant. This looks like a cholangiocarcinoma. These were both biopsied and were inflammatory pseudotumors, so better for the patient. Any questions? Okay, and I have one more case.